Andrew Seaman is an assistant professor of medicine at Oregon Health and Science University, boarded in internal medicine and addiction medicine. He is an educator, addiction medicine, and hepatitis C researcher, and a healthcare for the homeless clinician at Central City Concerns Old Town Clinic. His research passions center on the intersection of hepatitis C and injection drug use, and the implementation of trauma-informed care practices into healthcare systems.
Right, I am Andy Seaman. I'm an assistant professor of medicine at OHSU and the director of hepatitis and HIV services at Central City Concern. And I'm going to talk to you today in a couple of segments. The first is about our hepatitis C elimination program at Central City Concern in Portland, Oregon, and then also a heads up on a new resource available to us here in Oregon. So I'm starting with some learning objectives. The focus of today, or this section, will be the update on our elimination program and some review of our data on equity in hepatitis C treatment, and dried blood spot, which has arrived in Oregon, which I'm just so excited about, and we'll talk more about it in a minute. So this is our care cascade from May of 2017 through December of last year. And I'll show you a smaller version of this so it's a little easier to see. But in our program, which most of this time was based out of Old Town Clinic and then added in Blackburn Center, which are two FQHCs which have wrap services mostly for people living with homelessness or houselessness. And then also adding in Hooper Detox and Stabilization Center, which is a medically supported withdrawal center. And in that time, we screened we had almost 16,000 people coming through, with our implementation of our elimination program growing over that period. And we screened 4,600 people. Of those, about 1,200 were positive, and a little over 1,000 were initiated on treatment. Most of those completed treatment. And I'll show you this in a much bigger way just now, so you can really see that screening is obviously a big part of where we're still lacking, although the percent of folks screened is going up every year. And what we have here, this is looking just at our care cascade, starting at the HCV RNA positive individuals. So of the 1,174 people who were positive, we initiated 85% of them at over 1,000, which is in the literature about as good as it gets. We're really proud of our linkage to care programs. Of those, about 90% completed treatment, and of the folks at the time of polling this these data, which most of them were due for their SVR12 or proof of cure labs, 508 of them achieved SVR12. And I want to remind everyone what that means is 508 of them completed their labs and had a negative lab, and that big gap there really is not illustrating a bunch of treatment failures, but is illustrating the difficulty of getting this population in to get their hepatitis C confirmation labs. We had 9 likely treatment failures and 7 likely reinfections. It's always a little bit challenging to know which is which in our model of care, but bottom line is the people we're treating are by and large cured, but it's hard to get people into treatment. One of the things we are moving towards and are starting to do again at this point as COVID is letting up is we are incentivizing people to get their labs done. So most of these data that I just presented don't represent an incentivized model, but we are starting to incentivize people $15 to get their laboratory work done, and in certain settings. And then also, if someone who is engaged in our program decides to refer others into our program, so for instance, this is our incentivized model in housing, then one of these residents, you know, this green individual, resident 3, talks to 3 other people and says, hey, please come in and get your labs done. And when you get your labs done, that person who got their labs done gets incentivized $15, and the person who referred them in gets an additional $10. So we're kind of harnessing the capacity of the community to find other people who are at risk for hepatitis C, get them screened, and get them treated. And the rationale from this, besides just recognizing the work of what people in the community could do for public health, is that, especially among people who inject drugs, if you get people to refer folks in their community, we would hope that they're referring people who are potentially at risk for reinfecting that individual. So you're treating them in sort of a cohort and hopefully decrease the risk of reinfection and increase the speed of elimination. One of the things we've done that I think has a role in our successes in getting people initiated is we developed a lab algorithm, which I think I presented before to this group, and now we have data for it, which is that we screen through LabCorp. We basically, when people come in, they see an intake person at our clinic. That intake person offers screening to everyone. Then they get sent to the lab. If they go, they get a Hep C, Hep B, and HIV screening test. And then if the Hep C is positive, it reflexes to the confirmation RNA as well as everything that we use to initiate treatment. So that's their liver tests, Hep B, serologies, et cetera, and a pregnancy test if they're a woman. And the LabCorp test code, so this is not on their public menu, but you can use it. So if you use LabCorp, you can use one of those two codes. And with pregnancy is the top one, without is the bottom one. And those codes they will result in this test. And so you can skip that step of having people come back, ordering more labs, and having them come back again and start treatment. And so how does this work in reality? So this is a look at our data, a slightly different data set, but looking at on the left here, we did something called a multinomial logistic regression analysis, and we looked at multiple different predictors of treatment success or treatment outcomes, and those were, in our case, the site that they were screened at, their gender, their race or ethnicity, whether or not they got the laboratory bundle, drug use, diagnosis codes, which is suboptimal, but it's what we had at the moment, and housing status. And then controlling for all of those factors, we looked at how likely was someone to move from one stage of the care cascade to the other. And we looked to see if each individual intervention or characteristic affected that. And so I'll go over some of those equity data in a minute, but for right now, focusing on the lab bundle, the darker is no bundle and the gray is received the bundle. And what we found is that starting with just folks who are Hep C positive here on the left, people who received the bundle were more likely to be positive, which is interesting, more likely to initiate treatment, more likely to complete treatment, and really about the same as far as their ability to make it all the way to SVR12. So seemingly affects the early part of the cascade really positively and not as much effect as you get later on in the care cascade. That may reflect kind of the lower barrier nature of it, and so those folks might be a little bit harder to get all the way through to complete their SVR12 labs. On the right, we have a Kaplan-Meier survival curve, and again, what we have is now on the bottom here, that bottom light gray line is the pre-bundle period, so before we implemented the bundle, and then we have the post-bundle period, which also came along with universal screening practices initiated by non-providers. And what you see is that the top line, the black line, is that they were during the bundle period and they received the bundle, and the middle gray line is that they did not receive the bundle during that period. And what you see is that people are more likely to get treatment who receive the bundle, and they're more likely to get it sooner. So it's not a huge effect. I think the universal screening interventions that we've implemented in our linkage to care interventions are probably more important, but the bundle I think really was helpful. And these data are submitted to the International Journal of Drug Policy and they're under review. So looking at the other piece of this, which is really important. So with equity, I mean, we know that Indigenous people, people of color, women are often in many data sets less likely to be screened, less likely to initiate treatment, in some cases less likely to be cured, due to elements of systemic racism and gender disparity and so on. And so we wanted to look at that, and we did the same thing I just explained before, although this now includes screening as part of the care cascade. And we compared the controlling for all of these other factors, the housing status, to see what the effective housing status was on initiation. And that what we found is that people who are homeless in our model were more likely actually to get screened than people who weren't homeless. And that might be due to targeted screening practices that people might be more likely to get them in, but they were slightly more likely to be screened. And people who, but they did not have a really significant difference in whether or not they were positive. There may have been a slight increase in difference or increase in likelihood of positivity for homeless and transitional housing, but I think that's a little bit open. There was no difference between whether or not the people who were unhoused initiated treatment, at least statistically, or completed treatment. And then there was a difference, not surprisingly, that people who were homeless were less likely to complete their SVR12 labs. I think that's probably not a surprise to anyone. Moving on to looking at race, we found no difference in screening, which is a really positive thing. It means our screening interventions are fairly equitable from that perspective. There may be some difference in positivity, which probably doesn't have to do with our practices. But what you do see when you get down the line, so our initiation and treatment was great, which again, I think probably reflects the way we do things in a very universal, non-provider driven pathway. But the treatment completion, there's this, if you look at this unknown decline, this was the only racial and ethnic group that was not as likely to make it through the end of treatment. And that group is this unknown declined group in our data. And when we did a manual review of that, it seems like it's most likely reflective of Latino populations or Latinx populations, and maybe Pacific Islander. So, you know, it's hard to say what to do with this. We think this data suggests that our program is fairly equitable, but there's still some work to be done about as far as supporting people through the end of treatment. And then there's gender, and kind of a similar trend is that in the early parts of the cascade, our interventions are very equitable, but then you get further down the care cascade towards treatment completion in SVR12, and female identifying clients were less likely to meet those metrics than male identifying clients. And we don't have a trans group here because there weren't enough people statistically to look at them. So it's a weakness. But I think this just shows that we need to do more to support women and certain ethnicities through treatment to make sure that they have the same likelihood of success as others. I'm going to summarize. I think all of these remain fairly true for our substance use data. Basically, we do a good job of screening these folks and initiating, and that holds true through the end of SVR12 for people with substance use disorders. So what you're seeing here is that people with more risk factors or more substance use disorders, so people who use opioids or stimulants or both, are actually more likely to make it through the care cascade in our model than people who didn't. And I don't have a good explanation for that. All right, so our program is now expanding. We are currently at Old Town Clinic, Blackburn, these red ones in the middle, and Hooper Detox. We're moving back into housing. And then we have new partners with Allied, which is a opioid treatment program, and CODA, another opioid treatment program. We're formally going to be integrating dried blood spot screening, which I'll talk about in a minute, into those sites, and implanting our growing team of screeners and outreach workers into those sites to help relay results, incentivize results. So we'll be paying people for those labs and get them into care. And very similarly with Portland Street Medicine, Portland People's Outreach Project and Cascade AIDS Project, and these street medicine-based health fairs, we're going to be doing similar work with dried blood spot on the street. So dried blood spot, this is really exciting and important. We've been working on this for a couple of years. We now have the data. We have fully validated a dried blood spot test. So just for those who don't know, dried blood spot is a special card called Watson paper, and it's a finger stick. It can be done by the client themselves independently ideally with some support. But they poke their finger, they hang their finger over the paper, and they soak through this little circle. And what we validated was the hepatitis C RNA, so confirming active hep C, and the hepatitis B core antibody. And what the idea was, and then they had already validated the HIV antigen antibody, the hepatitis B surface antigen, and the hep C antibody. The idea here is that with the exception of liver function and platelets, this dried blood spot card has the potential to bring someone essentially treatment ready, so we could initiate treatment. And you could make an argument that people who are younger and have lower risk factors for advanced fibrosis, that you would not even need the liver function tests and the rest of that. So we're very excited about this. If you have anyone or a situation that you think you could use this card, we very intentionally validated it with a commercial lab. So this is something that could be used in the community as opposed to with a public health lab, which has a lot of challenges in implementation. The sensitivity and specificity in the real world validation, so the samples that we collected at Central City Concern in partnership with Molecular Testing Laboratories, our partner, were 100% sensitive and specific. When you looked at, and I'll give a caveat for that specificity, there was one false positive that was repeated and was negative, and they think that had to do with the number of cycles that were run, and they're working on that. So I think that's going to be worked out and will be at 100% specificity as well, which is what we see in the literature. So this is the first time this has been done in the US. It's been used all over Europe, Australia, but it's not been used here yet. It's also present in Canada as well. And then one of the things they do is they dial down and they look at, by diluting samples and comparing to lower viral loads to see what the lower limit of detection is, that it is not a perfect test. So when you are above 600 international units, sometimes people say copies of the hepatitis C virus, it has 100% sensitivity. When you get to 500, it drops to about 2/3, and then 250, about 50%, and 125, 50%. So there are going to be some folks who are missed. Probably a significant number of those will be clearing anyway with these lower viral loads, but not all of them. And so when you implement this, you want to think about what your screening program will look like. Do you want to repeat tests for high-risk individuals in 6 months, and so on? But we should be able to use this test to initiate treatment, which is very exciting, meaning they will not need a venipuncture follow-up for this. So I added in Brett Thorson, who's been my contact for the molecular testing labs, which is based out of Vancouver, Washington. If you want to start implementing dried blood spot, you'll need to set up a service contract with them like you would with any lab. I highly encourage you to reach out. This is a game-changing lab in that you don't need phlebotomy. It will allow us to get results for people who are very difficult blood draws. You can get them in the field, in the community, in treatment centers, etc. So very excited about this, and please do reach out. I just want to say I do not have any financial interest with this organization. So you know, email at will, and I'll defer to the community. So my recommendations here are, if you can, cut out the steps in the care cascade and you will increase your treatment initiation. Recognize the work of what people who use drugs do for public health, and incentivize, pay people if you can. I mean, I think for those of you who work in FQHC settings and you have a 340B pharmacy, this pays for itself. And you know, I think we should be recognizing their work. And then we all need to make sure that we're treating everyone with equity. And so if you have ways of determining if you are being equitable, then address it. And then also, if you don't, try to do things in a universal way to remove the implicit bias and other factors that that tend to decrease treatment and screening initiation in vulnerable populations. And then the dried blood spot, I think, again, I can't emphasize this enough. For us, it's going to be a real game changer, and I hope that you all can get some use out of it too. So with that, I'm gonna hopefully talk to you again, but it's been a pleasure, and I look forward to seeing you all in person again soon.